All right. Well, thank you so much for inviting me. I really am excited to be here and really am excited to talk about this topic. Although it's pain isn't always fun to think about, but I think it's relevant and important, and hopefully you do too. So I'll show my slides that I have. So can you see the PowerPoint presentation now? Okay,
Yes.
great. Let's see, that's not the right one. Hold on just a moment.
It's complicated is the first slide.
Yes, correct. Let's see, new share. Okay, so hopefully you can see the screen now. Let's see. All right, so just as Adrian mentioned, my work is funded by the National Institutes of Health. And it is my study that I'm doing right now is focused solely on low back pain in people with Parkinson's disease, and I'll mention why that is as we go forward. But just so you are aware. So my one main takeaway here today is pain is normal until it's not. So what I want to try to make a point clear on this is that pain is a sort of evolutionary feature that we have as humans that is a warning sign to basically tell you to stop doing something. So, for example, if you're hammering a nail and you hit your hand or you hit your finger with that hammer and you have pain, that's a normal thing, right? Because it basically is a warning sign, tells you don't do that again. Or similarly, like sticking your hand on a burner on your oven, you're gonna have pain right away, and that's normal. It tells you not to do it again. What the problem becomes is when that stimulus for the pain, so either the hammer or the burner from the oven is removed, and you continue to have pain long term, right? So it's probably normal if you hit your finger and you have pain, you're going to have what's called an acute response, which is like right away it's going to hurt pretty bad, and then over time that pain is going to gradually subside, and along the way it will go away at some point. When pain becomes chronic and it's still present and it doesn't go away, that's when we consider that to be problematic. And so that's what I mean by when pain is normal until it's not, okay? So specific to people with Parkinson's disease, pain is highly prevalent. And actually it's more common in people with Parkinson's disease than it is just age-matched older adults who do not have Parkinson's disease. So what that point tells us right away is that this is not just pain because you're getting older. People with Parkinson's disease have pain at a higher rate than those who do not have Parkinson's disease. We also know that pain negatively impacts quality of life. The relationship between pain and physical function is not totally clear yet, although there's emerging work that I'll show you in a bit that tells us that pain is related to physical function in people with Parkinson's. One of the main takeaways from this slide I want you to take away is that pain in a clinical sense is under-recognized and then under-treated in people with Parkinson's disease. So you can imagine, and even I'm guilty as a clinician when I would treat patients and they would come in and they would rightly have complaints about their walking or their balance or their slow movement or stiffness. I didn't think to ask much about pain, but I imagine that a lot of them had it and I just didn't ask. So what I want you to also take away from this is that you have to advocate for yourself as well. Although clinicians, we need to get better at it, you are also a very important part of the puzzle. And if you are having pain, we hope that you will tell us, because it turns out, and I'll show you here soon, that there's quite a bit that you can do for it, okay? Why is pain more common in people with Parkinson's disease? Well, to be truthful, we don't know the answer yet. So a lot of that work is ongoing. And that's sort of an aim of my study focused on low back pain, is trying to figure out what about Parkinson's makes low back pain worse or more common than it is just in older adults. There are several theories to potentially explain why pain might be more common among people with Parkinson's. The first one is that if dopamine, which is the common neurotransmitter or chemical that is released in the brain, in Parkinson's disease, that neurotransmitter is reduced. And dopamine, in addition to playing a key role in movement, also plays a key role in pain processing. So the reduction in dopamine may play a role in what we call the chronification of pain, or pain sticking around longer than it should. Another theory is that people with Parkinson's disease have what we call abnormal biomechanics. It's a fancy word for abnormal movement and abnormal postures. Okay, so you may see your friends, if you have people with Parkinson's disease at various support groups or things like that, that they may be bent forward a little bit or have odd joint positions. Those positions can often stress joints to the point where it could create some pain. And this, again, is common among people with Parkinson's disease. And then finally, people with PD have what we call non-motor symptoms, so things that are not related to movement, but are common. And these things are like anxiety and depression. And anxiety and depression are certainly related to pain and can also what we exacerbate pain or make it worse. So again, while what I think about this is that it's not just going to be one of these theories that solely explains why people with Parkinson's disease have more pain. What's going to be probably the answer is that it's a combination of all three, and probably other factors that I've failed to mention that explain why pain is more common among people with Parkinson's disease. There are different types of pain in people with Parkinson's disease, and I'm going to talk you through all of them, and then I'm going to focus on the top one, which is musculoskeletal pain. So I actually won't describe that one yet because I described that on the next slide. Radicular or neuropathic pain is pain that is associated with a specific injury to a nerve. So if any of you have had consider what sciatic pain, like the pain that is in your back and then runs down your leg, that is because there's inflammation or injury to a nerve in your back, and that pain travels all along wherever that nerve goes. So a sciatic nerve and its branches go all the way from your back all the way down to your foot. That's why when you have pain of that sciatic nerve, that pain can what we call radiate, which is why that is termed radicular, from all the way from your back all the way down to your foot. Dystonic pain is, I'll ask you all fairly soon once I stop sharing my screen and can see the entire group, but in Parkinson's, people can have what's called dystonia. Dystonia is an abnormal twisting posture. It often occurs in the foot or feet of people with Parkinson's disease. So if you pretend this is my foot, people with Parkinson's, their toes might cramp up like this. And that may be associated with like the off period of your medication cycle. And that dystonia can cause pain. There's also what's called central pain. This is perhaps one of the most least understood features of pain in Parkinson's disease, but this is, it's a inner sense of pain with no explanation as to why it's there. So for example, musculoskeletal pain, we might be able to say you have pain because you have arthritis, or you injured a muscle, or you injured a tendon, or something like that. The radicular pain, we can explain the pain because there was injury to a nerve. Dystonia, we can explain it because the muscle's cramping. But in central pain, we can't explain it. We don't know the origin of the pain. And then the last one, which I'm not really sure I agree that it's called pain, but akathisia is defined as sort of this inner sense of restlessness. So you just feel like you have to move. And the only way that that feeling would be relieved is if you actually do move. And this is also something.
I think we lost some video here or some audio.
Yes,
I'm going to take it now.
Can everybody hear Mr. Duncan?
I can hear you, but not him.
Yeah, same with me. I can't hear him either. Now it looks like we lost the video.
I stopped sharing for a moment.
Oh, I see.
There.
Can you hear me now?
Now we can.
Weird. Sorry about that. I
Yes.
don't know why that happened. Yeah, anytime that happens, if for some reason that happens again, just don't hesitate to reach out.
You were right in the middle of a great thought about akathisia.
Yeah, okay, great. Thank you. So akathisia is what's defined as an inner sense of restlessness, basically. Inside your body, for some reason, you feel like you have to move. And the only way that that sense of urgency or whatever can be removed is if you actually move. And this is associated with restless leg syndrome in people with Parkinson's disease. So I've explained the bottom four types of pain. Let me move on to the fifth type here in musculoskeletal. So this is the pain that is by far the most common among people with Parkinson's disease. And this is what you probably typically think of when you have pain. Oh, my joints ache. I may have some cramps here and there. Your pain might be worse when you wake up in the morning, and it might go away or reduce a little bit as you start to move. This is what we consider this typical musculoskeletal pain. One of the couple of the points that we know is that it may be exacerbated. Exacerbated means worsened by rigidity. So muscle stiffness can make this worse. Interestingly, moving probably makes it better a lot of the time. No, not all the time, but a lot of the time. And then other times it may fluctuate with your medication cycle. So if some of you have points at which your medication works well, your pain might be better. And then that medicine wears off, your pain might be worse. So that's possible. And that's something at the end, I'm going to ask you to pay attention to as you go along. I missed the title of this slide. Look, the prevalence of pain, musculoskeletal pain in people with Parkinson's is astonishingly high. So 70%. In typical older adults, it's around 40-ish%. Okay, so again, this tells you something about Parkinson's disease is making pain express itself more than it would if you didn't have Parkinson's disease. So multiple joints are commonly painful among people with Parkinson's. So you can have the neck, which is common, shoulder, which is common, low back, knee, and foot. Okay, so I will explain to you why all of these are common. So the neck is a common place that people can also have dystonia, which is, again, that abnormal muscle cramping. So some people might have a muscle cramp that pulls their head to the side like this, or if I turn this way, it might pull their head forward. When your neck ends up in an abnormal posture over time, and that is sort of stays consistent, you can predispose those joints to becoming painful. The shoulder is an interesting one in people with Parkinson's disease. So can you still hear me?
Yes.
Okay, great. The shoulder is an interesting one. This one is, so I'll preface this slide by saying the shoulder and the low back are the most commonly studied joints for pain in people with Parkinson's disease. And even though I say they're commonly studied, there's not a whole lot of research on them. But nonetheless, that's where most of it is focused. The shoulder is most commonly painful on the side that your symptoms are most manifested. So if your left side is most affected by Parkinson's, so meaning that side is a little bit slower or more stiff, you are more likely to have shoulder pain on that side. We're not really sure why. There's, again, a couple of theories. Is that so the side that's more affected by Parkinson's disease tends not to move as much as the other side. And that lack of movement interestingly, can contribute to problems within the joint, which might cause joints or muscles to become, to degrade. And so the lack of movement could contribute to tissue problems, which could then cause pain. Again, these are theories at this point that need to be borne out by evidence, but that's the prevailing wisdom right now. In the low back, this is by far the most common site of pain in people with Parkinson's disease. So there's studies to suggest upwards of 75% of people with Parkinson's disease have low back pain. We probably know the most about low back pain in Parkinson's disease, although what I would consider know very little, that it may be related to poor posture, it may be related to muscle stiffness, and it does affect your movement. It's thought that forward bent posture could contribute to the pain. And so that's one of the things that my study I'm working on is to try to tease apart, and I'm happy to talk about that a little bit later. The knee is another common place for pain in people with Parkinson's disease. One hypothesis is that when you walk with a shuffled or slower gait, your knee remains bent throughout most of that walking cycle. And when your knee's bent during walking, there's increased stress across that joint. And so if you're consistently placing increased stress across a joint, you are more likely to experience pain. And then finally, the foot is a common place for pain because, as I mentioned, that is a common place for dystonia, which is that abnormal cramping of your foot, and that can often produce pain. So pain negatively impacts the lives of people with Parkinson's disease. And it doesn't just happen due to age. This may be, again, we hypothesize that it's related to muscle rigidity and poor posture. But we also know that anxiety and depression are associated specifically with low back pain in people with Parkinson's disease. And we guess that it's probably related to the pain at the other joints as well. And we know also that in people with Parkinson's disease specific to low back pain, those who have more severe pain move less and have lower quality of life. That's purely a relationship though, and this is important to understand, is that we can't say that low back pain causes you to move less. It could be that moving less causes you to have low back pain. So that the direction of that relationship needs to be studied more, and that's what we're planning on doing within my study as well. So what should you do if you have pain? I think the most important thing for you to do is discuss it with your neurologist to first ensure that they are aware of it, okay? If they don't know that you have pain, that like I was doing in my clinic, I wouldn't do anything about it because I didn't know it. Again, I should have been better about asking, but both of us working together can effectively manage the symptoms that you have, and so pain is one of them. And if you have it, don't hesitate to mention it. The other important point I want you to take away is that if you have pain, I think it would be ideal for you, particularly you and your neurologist, to know whether your pain fluctuates in the same way that your medication might fluctuate. So some of you may not have fluctuations in your medication at all. You may take your normal dose and you don't really notice whether it is on or off, or you take it and it's always on and you notice that. That's great. If you have points where it's more like a roller coaster, where it's on for some points and off for others, track your pain during those on and off times and see if the pain is better when it's on and worse when it's off, or vice versa. It could be that. That will be important for your neurologist to know, because if the pain coincides with that fluctuation in your medicine, they can work on trying to smooth out those fluctuations so it's less like a roller coaster and more like a straight line. Okay. And then finally, I'm sure Meredith talked to you a lot about exercise and how important it is. But again, I strongly recommend exercise. And there is evidence, not specific to people with Parkinson's disease, but specific to older adults, that exercise can have what we call a powerful analgesic effect. So analgesic means reducing pain. And so exercise can be a means to try to reduce the pain that you have. And at least if you're not on a exercise regimen now, but you like to start, I do strongly recommend that at least you start out with some supervision by a trained clinician specific to Parkinson's disease that can help you get started so that you don't potentially injure yourself further if you are in fact injured to start.
What kind of exercise is ideal?
Great question. My answer is always the one that you're going to do. So I think there are a lot of what I would probably term camps in the field of exercise in Parkinson's disease. You have some people who really advocate for treadmill walking. Some say boxing is the best. Some say dancing is the best. I honestly think they're all great. And I think that the one that you're going to do and the one that you're going to stick with is the one that you should do. So I always tell people, if you are, so myself, I don't care to dance that much. So I'm not going to start a dance program because I'm likely to stop that. And that's not the goal. We want all of you to be lifelong exercisers. And the best way to do to stick with something is to do something that you can enjoy. So if you enjoy walking, make walking your exercise. If you enjoy boxing, do it. That's great, but stick with it. Specifically for pain, now that's a sort of another level of that. This is where treatment by a clinician might become important. So if you find that the pain is related to a specific muscle or muscle groups, the clinician then can help you figure out how might you target that. Is that a muscle that you need to get stronger? Is that a muscle that you need to stretch because it's really stiff? Things like that. So if you're looking to exercise specifically because you have pain in a certain area, you may consult the clinician first to make sure that there's not something additional that you could do outside of your typical exercise regimen. Good question. One other takeaway point that I feel like I should make, because over this past year, when I haven't been able to collect data in the lab, I spent a lot of time reviewing the literature on musculoskeletal pain and how it's managed in people with Parkinson's disease. And one of the ways that pain can be managed in people in general is you can have surgery for pain. So for example, if you have severe knee pain, you could have a knee replacement. If you have back pain, you could have a fusion or something like that. What I do think you should be aware of in the literature that tells us, so the evidence, the science, tells us that because you have Parkinson's disease, you may be at higher risk for the following three things. Surgical complications, so meaning you may be more likely to have an infection after surgery or a longer hospital stay. Number two, you may be at risk for poor surgical outcomes, meaning that you don't regain the function that you thought you would get from a certain surgical procedure. And then finally, which is what probably nobody wants who undergoes orthopedic surgery, is you may be at risk for having to overdo it or redo it again. So what's called a revision surgery. So for an example would be if you have a knee replacement and then 6 months later, it just doesn't feel right. It's still hurting. They may have to do it again. So take it out, put a new one back in, and that's not something anyone wants to do.
Did someone have a question or a comment?
Yeah. I think Anne, did you say something?
I'm sorry, my computer went dead.
Oh, okay.
I got a flash too. I think the internet is acting funny today.
Oh.
I got a bright flash.
Okay, but you can still hear me and see?
Yep,
Now
good.
Great. Okay. So I raise these points because I think that it's not to say you should not have orthopedic surgery. If that is something that is indicated and warranted and is a way to potentially fix pain after you've tried other more conservative measures, I think it's okay to have surgery. However, I say this important caveat at the end that your neurologist should be intimately involved with the orthopedic surgery procedure that you're about to undergo. All right. I don't know if any of you've had experience, but what we hear a lot is that if you go into the hospital, a lot of people have challenges, that's probably putting it nicely, of maintaining their typical medication regimen, because now you're essentially handing the pills over to the nurses. The nurses are busy and they may not have time to get you your medicine at the specific time that you need it. And we know that you specifically need to take your medicine when you're supposed to take it on time. And if you don't, there are effects of that. And this is why hospital admissions become tricky for people with PD. And so we think that might be one reason why you're at higher risk for these sort of suboptimal outcomes following surgery. Okay, so it's not to say don't have surgery, it's just to say that you need to have a big, strong team approach, and your neurologist needs to be involved if you are going to have surgery. All right, so takeaway points. Although pain is common among people with PD, there are many options for treatment. And I would say the first one, again, is starting with exercise. And again, if you have not started a regimen yet, consult a professional before you do start. If pain is impacting your life, let somebody know about it, and particularly your neurologist. Because again, there are treatments that they can do. There are different, I'm sure they'll recommend exercise. There are medicines that they might be able to give you that could help. And so be aware of that and advocate for yourself. And then finally, I'm always, as a physical therapist, and I know Meredith as well, is a huge champion for exercise is cheap. And I put maybe effective in parentheses because I'm a big fan of science and evidence. And because we don't have it specific to Parkinson's disease yet, that exercise can be an effective means for managing pain, I don't want to overstep my bounds. However, given it is low risk, cheap, and likely effective, I think it's something that you should strongly consider for managing pain if you have Parkinson's disease. All right. So I'll put my contact information here for those of you who, you can always send an email if you feel like you have questions. I know Meredith is a fantastic resource, so I'm sure she would be a great person to ask questions to, but just in case you need it, feel free to contact me at any time. So I will stop sharing now and would be happy to have a discussion about any of the points I raised or any other questions that you might have.
Ryan, I've had Parkinson's for a little over 11 years now. Still fortunate. I'm still able to exercise and move around quite a bit and that kind of stuff. But in the last couple of years, I've noticed lower back pain, not due to any injury. I've never had pain in my back before. That's, from what I'm hearing you say, that's something that's just a symptom of Parkinson's. You just kind of get it and you don't. I try yoga and stuff like that to stretch and do certain exercises to strengthen my back, but that seems to have little impact on the pain.
Yeah, so thank you for sharing that. I do think it is what we would consider a manifestation of Parkinson's disease. So, and I shouldn't be specific to low back pain, again, pain in general, but low back is one of the most common places where it occurs. What I do think you're doing the right thing is trying to find certain sort of treatment options that might work. What I don't think you should do is just chalk it up to say this is normal and I was going to have it, and and I'm just going to have to deal with it. I don't think that's an approach that any of you should consider. And so this is again why I say mention it to your neurologist, see if they have options for you. Like I said, track it, see if it's worse when you wake up in the morning and it goes, if it reduces as you start to move. Those are indicators that could be something helpful for clinicians to know if you seek out help for that. But yeah, it does seem to be that people who have had Parkinson's disease for a longer period of time tend to develop low back pain more. So it could be associated with disease duration, although it's not always. Some people some people have low back pain that precedes their diagnosis. So it's a tricky slope there.
Well, I don't know how many people have had a surgery or a hospital stay. I recently had one and experienced what you mentioned about getting your medications. And I guess what I noticed was I had to be very much my own advocate. And I took my own. I insisted that those were the ones I wanted to take. Of course, they took them from me. And then I told them to schedule, to set their own schedule. But anyway, I just they really did well, but you have to really be an advocate in that. So
that is a fabulous point, and thank you for sharing that experience. I mean, and that is not uncommon in any way. And luckily for you, you were a strong advocate for yourself to make sure that you got the treatments that you needed when you needed them. We've had people, and our neurologists that I work with are very wary when they hear people going into the hospital because they're worried about exactly what you're saying. And we've had people get sort of quite a bit worse when they go in the hospital because their medications get all out of whack. And that's not something that you want. I know that this organization is associated with the Parkinson's Foundation, which they have fantastic resources for, basically preparing or dealing with a hospital stay. Usually, I think they even have like printout cards that you can print out and give to the nurse or the doctor as soon as you get to the hospital and say, this is key and you need to pay attention. And also, if you, like you, Carol, said, like, try your best to say, let me have my medication. I know when to take it. I know that I need to take it at important times. A lot of times they won't let you because hospitals don't let people have their own medications in sight. But some are coming around on this, and so you may just keep trying. But good.
Ryan, if I could interject, I've had Parkinson's for about 5 or 6 years. I just had a recent set of surgery. I do use it's the Parkinsons Kit. Right, it does have a list you give to your surgeon, you give to your anesthesiologist, your nurse. The other thing I found that helped is that I talked to them weeks before the surgery. I made an appointment and I sat down and I looked at that surgeon in the eye and I said, let's talk Parkinson's. Here's your piece of paper. What am I allowed to do? What is my husband allowed to do with my medications? And because we took the time, I was allowed to have the medicine with me.
Wonderful.
And when it was time, I took it.
That's great. Thank you for sharing. I strongly recommend, and this is, because not all hospital stays are planned, this is something that you might have ready to go, and let your significant other or caregiver know that that kit is there, and if we have to go to the hospital at the last minute, you bring that kit, because that can be a really, really helpful resource.
It's called Aware in Care. It's an Aware in Care kit, and it's free.
Great. Yes.
Michelle, where do you get that kit again?
Parkinson's Foundation.
It's on the Parkinson's Foundation website.
you do have to pay postage,
Okay.
but that's all. I think it's $5.
Sounds pretty effective, though. Sounds like you all have had some good results with it.
Yeah, I would say well worth it.
Could you speak
You
to
can
what,
put your list of doctors and your list of meds in there, hand it to them in one little pack.
Great. John, it sounded like you had a question.
yeah, I just had a question. I don't have like an acute pain. I have more of a phantom pain that comes with not being able to move. I mean, when my medicine is not working, which is a lot of the times recently, I get to the point where I literally can't move my hands or my arms, and I don't want to say painful, but it is painful in a way. It's mentally draining, and
Yeah.
and it's a hard pain to describe to anyone. It's like I'm trying to carry my house around with me all day long, or some immovable force I'm trying to move.
Yeah.
Could you speak to that pain? I mean, that to me is what I've been battling the worst lately.
Yeah. I'm trying to think of if I could explain it.
It's exasperating. I mean, it just drains you physically and mentally because you can't do what you want to do.
Yeah. So one of the ways that pain is defined now is pain is a abnormal sensory or sorry, I shouldn't say abnormal. It's a sensory and emotional experience associated with either actual or potential tissue damage. Right? So in your case, it could be that sort of potential tissue damage piece of it that, like, if you don't move over time, again, it could result in pain. And so maybe that's part of what's going on. I also think, like you're saying, that the effort that you have to put into trying to move probably also contributes at some point to this feeling of pain or discomfort. And so
it's almost like the more effort I put in, the worse it gets. I find that if I lie down and just listen to music and relax, I can usually get out of that pain within 15, 20 minutes.
yeah,
So it's a balance, you know. I
Yeah,
walk a
that's
lot. I do 10,000 steps a day, but
great.
I just
Yeah,
get to that point where you can't go on.
yeah. The other thing is that stress can exacerbate pain. And so, you know, you could consider that situation, and like, just like you're saying, where if that situation where you're trying to move but you can't becomes stressful, then that sort of feeds into the worsening of pain, which then worsens your stress, then
Right.
Right.
worsens the pain, and it's sort of like a cycle. So I would, if you haven't, and I imagine you have, but if you have not, consult your neurologist, because they can consider tweaking your medications to see if they can minimize those times where you have that feeling.
Yeah,
And
the
I
medicine has
wouldn't wait.
become less. I'm scheduled to do a DBS surgery in the near future, but it's just the medicine just isn't doing it anymore.
Yeah. Yeah. It sounds like you're in close contact with your doctor. I think just keep telling them that what you're experiencing, and hopefully they can find ways to manage it for you.
Yeah.
Yeah.
Thank you.
Mm-hmm.
Ryan, are there any things that you suggest from a diet or nutrition perspective? I try and eat a lot of pineapple. I understand that's good. And I take glucosamine to try and keep your joints somewhat loose. They're not loose with Parkinson's, but
Yep.
looser.
Yep.
Is there anything else you can suggest?
That's out of my bounds. So I wish, I mean, I would honestly tell you to consult a professional in that area who could give you more information. And because people with Parkinson's disease do have unique diet needs, I don't want to say anything that would conflict with what is best knowledge or practice out there. But I think the main thing that I can say that I just said, and if you haven't heard it yet, diet is very important for people with Parkinson's disease, particularly because it can cause interactions with the medication, particularly as to when you eat, and what you eat when you take your medicine. And if you don't know that, so then that's another reason to consult a professional on that. So I wish I had more information for you, but I think it'd be better for you to get it from somebody who's trained in that area.
Greg, what's the connection between Parkinson's and pineapple? That sounds delicious.
Yeah, it sure does.
Pineapple supposedly has a chemical in it that helps lubricate your joint, makes it easier to move. And then glucosamine is a natural found substance in your body. You're just trying to enhance that, again, for joint lubrication. Certainly I've experienced, as you get older, you get sicker. And then in the last couple of years, I've started to experience dystonia, especially when I wake up in my feet.
Mhm.
To kind of loosen up my feet. You gotta be careful walking because you don't have your balance quite as well.
Right.
Tends to go away once you start moving around a little bit. So
Yeah.
So just a few pieces of pineapple a day, or
yeah, I have it every morning at breakfast. I try and have it works for me. Half a banana and blueberries, pineapple and strawberries.
Great.
I make a pretty decent pineapple upside down cake. You're all invited over.
All right.
Sounds delicious.
Mail mine to Florida.
Okay.
I will say one of the points that I wanted to try to make in that talk is there's sort of a continuum on which we think there is sort of what we would say optimal movement in relation to pain. So if you, on this hand, you have like virtually no movement at all, and this one you have way too much movement, either one of these is associated with pain, right?
Yeah.
So people think, well, I'll feel better if I just stop moving. Like, well, no, you actually might make yourself worse. So you want to be somewhere here in the middle where you continue to move on a regular basis, but not too much, not too little. And that's, each person has their own sort of sweet spot. But I hope you understand that not moving is not the solution, because that's very important. Yeah.
Have to get our health to cooperate with us, give us more opportunities for physical therapy, and I just don't understand why so many medicines are covered by health insurance and exercise is not. I just don't get it.
You and me both. And I fail. I mean, I think I know what's at play there. I mean, it's the lobbying power of the drug companies and things like that probably play a massive role in that. To be some of it's on patients too. Like the people we always say if exercise was a pill, everybody would take it, right? But sometimes pills are easier than exercise. Exercise requires you to work, and some people don't like to do that. And so, but that's again not a reason that people shouldn't have access to it. I am a big advocate of making access to physical therapists or other exercise professionals accessible. I mean, to be completely honest, like even I work at an institution, a research level hospital, a top tier hospital in St. Louis, Missouri, and my benefits require that every time that I go to a physical therapist, I have to pay a $25 copay. Like that is, and imagine if I had to go 2 or 3 times a week, and then I had to go for a month. That's half a house payment, right?
Right.
That's nuts. And I just don't get it. So what I hope over time that insurance, I mean, the other part of that is I don't understand why insurance companies pay an incredible amount of money for medicines and for surgery. And in the long run, physical therapy is incredibly cheap for them. And I don't know why they haven't come around to sort of understanding that yet.
Yeah.
I think they are slowly coming around to it. Like, for example, there was a pilot project by United Healthcare for people that had low back pain. If they went to a physical therapist before they went to their doctor, they didn't have to pay copays. And they started to find that was effective, and the reason was because as soon as you go see a doctor for low back pain, you're going to end up with an x-ray, which is a lot of money. You're going to end up with pills, which are a lot of money.
Yep.
And then a lot of times the x-rays don't, this is another piece, important takeaway is that findings on imaging. So like if your doctor takes an x-ray of your back and says, oh yeah, your pain is because you have, really bad arthritis. Well, maybe, but pain is often poorly related to imaging findings. So just because you have Like I could go in, not have pain and have terrible findings on imaging. And then it's sort of like, well, how do you explain that? So be aware of that too. Anyways, I agree. Physical therapists should be accessible. And I think, you know, sometimes you could even take it upon yourself to call your insurance company and tell them, listen, you need to help me out here. This is effective treatment for me. It's cheaper. I don't want to take medicines because medicines have side effects, things like that, and see what they can do. Yeah, good
I'll
point.
tell you something really crazy, and that's I had to get a battery replaced in my neurostimulator, and the other one wasn't ready to be replaced. And I thought, I said, well, while you're in there, just do the other one. And they said, no. But now I have to have the other one replaced. And the other one was replaced 1.5 years ago. And now they got to go through all this, going to get anesthesia and outpatient. And it was probably like $5 battery.
I mean, I don't mean to be, I'm not going to make this political, but when you start to mix, how do insurance companies make money? They make money by not spending it on you, right?
Yeah.
So that's their whole gig. The less money they spend on you, the more they get to take home. And so that's a lot of the why we're in this problem that we're in the United States, where we have the worst health in the world, is because people don't have access to the treatments that they need. Pure and simple, really.
Thank you for sharing that.
Yeah.
Ryan,
Absolutely.
are you familiar with LSDT Big?
I am. Yep.
How do you feel about that program for exercise?
I will say that if that's the exercise that you like to do, you should do it. I will also say that there's evidence to suggest that it's no more effective than other types of exercise. So one of the things I will tell you to be aware of is that branded treatments like that, they're branded for a reason, and that's because that company that brands them is finding a way to make money off that somehow. So again, if that's what you're going to do and you like that very regimented protocol of you do these specific movements, you do it this many times and things like that, and that's what you're going to do, by all means, absolutely do it. If you're not somebody who likes that and you like more freedom to do other forms of exercise, you should do that instead. So hopefully that's clear.
Yeah.
Yeah, you know, it is very popular among treating clinicians, especially physical therapists. I think one of the reasons physical therapists like it so much is because it is a regimented sort of protocol for treating Parkinson's, at least with exercise. And my take on it is that it's too narrow in focus. It sort of assumes everybody has the same problem, and I don't think that's the truth in Parkinson's disease. And that's why I advocate, or when I was specifically treating people in the clinic, I took much more of an individualized approach to figuring out which exercise is best for you. And if I thought doing big movements was important for you, then I would help you do that. But if I didn't think you needed to focus on that, but instead should focus on strengthening your muscles or working on your balance or exercise like cardiovascular, then I would do that. So
Might
good
be
question.
something that a person could do in addition to other activities. Variety is the spice of life. So
You got it. You got it. I found two types of people, you know, as I was treating patients. Some people really love the routine. They want to do the same thing every day. Yeah, right. And other people, you know, I get bored by doing the same exercises, you know, day in and day out, and I need variety. And then that's great. So whatever works for you. Again, I'll stick to my mantra. The best exercise is the one that you're
When you'll do, I agree.
Yep. One piece I'll add to that, that we're starting to find is that you need to make sure that the exercise you do taxes you or makes you work at least a little bit hard. So if you're spending a lot, if you're doing an exercise program, but you don't really feel like you're working, that's probably not enough. And that you need to at least feel like you're working when you exercise.
And you know, Ryan, to add to that, in my opinion, that's why you have and the physical therapists of the world to guide you. And what she's done for me is she's got a wonderful blending of the big and loud and the powerful programs with strengthening and balance that is specific to me.
Yeah, that's great.
You know,
that's exactly what you need.
Too.
Yeah.
So we've got just a few more minutes with Mr. Duncan. And Ryan, did you want to speak about your study? Was there a study that you wanted to talk about?
Yeah.
We just have a few minutes, and I have to keep a few minutes at the end to take down people's names. I don't have complete names for
sure.
people. So could I turn it over to you for a few more minutes and
that's
talk
great.
about your study? And and I'll ask everybody for their names for Meredith's role requirement.
Right. Yeah, I'll just keep it very brief. So given that low back pain is the most common site for pain in people with Parkinson's disease, we wanted to study that in an attempt to start to figure out what are factors that differentiate somebody with Parkinson's with low back pain from somebody with Parkinson's who doesn't have low back pain. And if those things that we find are different, then we can potentially use those as treatment targets, if you will. So if we find that people with Parkinson's who have back pain have worse posture and more stiffness, then we can say, okay, our treatment should focus on improving posture or reducing stiffness. So that is the sort of the main focus of it, of the project. And so we are actively recruiting now. I know I'm in St. Louis, so it's probably highly unlikely that any of you would ever participate in my study. But if you're ever in the area and you want to, let me know. It's just a one-day study. It's only 3 to 4 hours of your time. We do pay people $25. It's not enough, but nonetheless. So yeah,
it's National Road Trip Day.
It is right down Route 66, like you
trip.
said. You'll end up right in St. Louis. So I just want to thank all of you for letting me speak today. I really appreciate it. I love engaging with the community and really appreciate the opportunity.
Well, thank you for your help and your information.
Yeah, thank you.
Could I please ask the attendees to, I'm not familiar, as Meredith is so familiar with everyone, I need a little help with the names. There's a attendee named Bill T. Could you please give me your last name?
Yeah, it's Tomerlin. Tomerlin.
Thank you. And Joni, are you still with us?
Yes.
Would you please
Joni.
give?
Last name? Townsend. TOWNSHEND.
Thank you. And Carol?
Matthews, MATH.
Matthews. Okay, thank you.
Okay.
And I think we are good to go. And I hope everyone enjoyed the presentation today.
Definitely.
We'll look forward to our next educational meeting. It'll be the 4th Friday of next month. And I wish you all a very happy and healthy weekend.